Good afternoon, dear doctors. We are about to begin. Please be seated, stay online, and make yourselves comfortable. To start, let us seek divine intervention through an audiovisual presentation of the prayer and followed by the singing of Lupang Hinirang.
Let's bow our heads and place ourselves in the presence of the Lord. Dear Lord, we stand before you in humble prayer before we start this program. We realize that without your blessings, we would not be able to succeed with the plans we have for this activity. Bestow your grace and divine wisdom to all of us present here, so we could cooperate and enjoy camaraderie and love for the greater glory of your name. Bless also those we have left behind our homes. May you grant them peace and happiness as they go about their activities. Bless people around the globe that they may enjoy peace and the goodness of your love. We ask all these through your mighty name. Amen.
Mga kababayan, ang pambansang awit ng Pilipinas. Kayang magiliw, ay masasiranganan, alam ng puso, sa dikit mo'y buhay. Lupang hinirang, tuyag ka ng magiting, sa manlulubing, di ka pasisigil, sa nagatang tutok sa simoy at sa langit mong pagaw, ay hinagang tulad awit sa pagkayang minamahal. Ang isang ng atawad mo'y tagumpay na nagtitingin, makituwin at araw niya kailan pang ay magtitingin. Lumanang araw ng warhabit pagsikta, mo'y langit sa piling mo. Ang inigaya na partay mga amin, ang mamatay ng dahil sa'yo.
Magandang hapon po ulit. I am Sheila Peñafiel, Regional Sales Manager of AZ Pharma, and it is my delight and honor to be with your host for today's Leflunomide webinar. To formally open and to give us the words of welcome, it is my distinct privilege to introduce to you the ever-dynamic, approachable, and distinguished PRA President, Dr. Emmanuel Perez.
Good afternoon, everyone. Thank you very much, Sheila. I will just keep this brief and short. This is just very, very exciting for the Philippine Rheumatology Association for the practicing rheumatologists to be able to get access, and to be able to prescribe this disease-modifying anti-rheumatic drug, for rheumatoid arthritis, leflunomide. Everyone has been waiting for this drug to reach the Philippine shores, and now that it has, I think everyone is happy. So I am just very, very glad that Sheila, through AZ Pharma, has brought it to the Philippine shores, and rest assured that in behalf of the patients with rheumatoid arthritis, we would like to thank the company for bridging that gap, and I would be very, very intent on listening to our very, very well prepared speaker, Dr. Salido, because even if leflunomide is a relatively old established drug, it is kind of new, reaching our shores again in the Philippine shores, because we have been waiting for this for the longest time. So thank you very much, dear PRA members, and thank you very much again to AZ Pharma, and advance thank you to our speaker and moderator.
Maraming salamat po ulit, Dr. Emmanuel Perez, for that heartwarming remarks. And with that, may I call on Dr. Bernadette Hazel Manapat Reyes to introduce our speaker.
Good afternoon, fellow rheumatologists. We're very happy to see everyone here today. I have the honor of introducing our speaker. She's very familiar to all of us. Probably most of us know her as a past president of the Philippine Rheumatology Association. To those of us who have had the privilege of being her trainees, she's like a core trainer, especially in the field of research, being very qualified, having earned her master's in clinical epidemiology from the University of the Philippines, Manila. In addition, she is our fearless leader in the Division of Rheumatology, Department of Medicine in PGH as of present, where also she serves as a professor at the College of Medicine. Likewise, she's a professor in the Department of Clinical Epidemiology of the De La Salle Health Science Institute. Alam niyo ba yun? And is the chief of the Division of Rheumatology and is a consultant at Asian Hospital and Medical Center and Perpetual Health Delta Medical Center as well. Now, I will just focus on the things that you probably don't know about our speaker. First of all, did you know that over the past 5 years, she has been a member of 4 national and international technical working groups, not just for rheumatologic conditions such as gout, but also for the COVID living guidelines for tuberculosis and even hemodialysis. Over the same period of time, she has also headed 3 technical working groups for cancer for DOH, and is presently the chair of the steering committee for musculoskeletal disease screening of the PHEX program of the Department of Health. Enviably, he has published 25 journal articles, most of them in peer-reviewed index journals in various topics of rheumatology. I think we would be hard pressed to find somebody more qualified or more scholarly than our speaker this afternoon. So, ladies and gentlemen, please welcome with me our speaker, Dr. Evelyn Osho Salido.
Hello, good evening. Thank you, Hazel, for your warm introduction. Parang kinabahan ako dun sa introduction na yun. And thank you, Noel, for giving us very encouraging welcome remarks. I'd also like to thank AZ Pharma and PRA for giving me the opportunity to talk to friends and colleagues this evening. So this lecture is about leflunomide in the treatment of rheumatoid arthritis. I'd like to talk a little bit about its pharmacologic properties, its clinical efficacy and safety in the management of rheumatoid arthritis. And I hope that when we all go home, we will be able to apply this knowledge about leflunomide in our clinical practice. First, let's start with the story of drug discovery in rheumatic musculoskeletal diseases. I'm sure you've seen this slide many times, but tonight, I'd like to show this slide, tell you about this story and how it relates to my life. So I was born in 1963, and at that time, there were 5 drugs available for the treatment of rheumatic musculoskeletal diseases, namely NSAIDs as a group, gold salts, and I believe this was the intramuscular form of gold, sulfasalazine, and glucocorticoids, as well as hydroxychloroquine. 20 years later, when I entered the UP College of Medicine as a first-year student, there were 3 additional medications which were available, and these were D-penicillamine, azathioprine, and cyclosporine. And by the time I took the board exam, that was in 1998, there were 2 more
which became available in our therapeutic armamentarium, which were the oral gold, auronafin, and methotrexate. And I remember this was also the time when our moderator, Dr. Penserga, started her career at the UP College of Medicine. So she was a young faculty then. So let's fast forward to 1998, which is 10 years later. And this was when I gave birth to my second child, Isabel. I'm sure many of you know her, no? So at this time, 1998, this was a very important year for rheumatology because this was the year when etanercept was introduced, and we recognize this as the beginning of the biologics era. But, and you know, after that, 1998 to the present, we have seen a revolution in terms of drug discovery for musculoskeletal diseases, for rheumatic diseases. And but what's also very important or special for 1998 is that it was when leflunomide was approved for for its use in rheumatoid arthritis. And you know, when I was reading about leflunomide, preparing for this lecture, I was so surprised to discover that its parent compound was in fact used initially as an agricultural pesticide, and it was a a finding later on when they were studying it in animals that it had immunosuppressive properties. So after several chemical modifications, the drug leflunomide was born, and it was studied for the next 20 years until it was approved for rheumatoid arthritis use in 1998. And I remember in 1999, I was still a young consultant then. I remember Dr. Clemente Amante had a clinical trial on leflunomide, and I believe that his sub-investigator then was Dr. Hazel Reyes. So we were then all very excited to welcome leflunomide in the Philippines. However, unfortunately, it only stayed in the Philippines for a few years, and it disappeared from the market. No, and of course, the rheumatologists were all very sad because of that. And now, 15 years later, we welcome it back, and we are uh, rediscovering its use for um, for rheumatoid arthritis and other diseases. Okay, so what is leflunomide? It's actually an isoxazole derivative. So it's a prodrug, no? And so this is why it's called an isoxazole derivative, because of this ring. And it's a prodrug that is actively and rapidly converted to its active open ring metabolite, which is you see here down below, which has a long chemical name, but has the shorter name of teriflunomide. The rapid conversion from leflunomide to teriflunomide occurs in the GIT mucosa and in the plasma. And when you change several parts of this molecule, leflunomide, if you change this trifluoromethyl group to a lipophilic group, that will increase the efficacy it has a half-life of around 2 weeks. During the first 4 days of its use, renal elimination predominates. However, eventually, the elimination through the stool and the urine becomes almost equal, a little bit more in the stool. So this slide is telling us that this gives us proof that teriflunomide is indeed the active component of leflunomide. And sensitivity, it's very sensitive in predicting a good response to leflunomide. Okay, so let's now go to how leflunomide acts. Leflunomide is a selective inhibitor of the de novo pyrimidine synthesis. So basically, it prevents cell synthesis. No? It reversibly inhibits the enzyme dihydroorotate dehydrogenase, and this is the rate-limiting step in the de novo synthesis of pyrimidines. So if you have a process like rheumatoid arthritis, wherein you have active cell proliferation, active lymphocyte proliferation, there is an eightfold expansion in the pyrimidine pool that occurs and a twofold increase in the purines. So you can understand that if you inhibit the enzyme dihydroorotate dehydrogenase, essentially you prevent cell proliferation, and by that you are able to stop many processes. No, you can also suppress inflammation through inhibition of cytokines like interleukin-1 and TNF-alpha, and prevent the activation of nuclear factor kappa B. Also, we will be able to downregulate the glycosylation of adhesion in suppressing the inflammation in rheumatoid arthritis. So when leflunomide is taken orally, it's absorbed very fast. And in the liver, some of it is eliminated, no? But most of it is converted into blood and in the liver to teriflunomide, and it is actively taken up by albumin, so it becomes bound. More than 99% is bound to albumin. And also, through the action of several enzymes, eventually it's eliminated through the bile. But very important in this diagram, which is why I showed this, is the enterohepatic circulation, which can explain the prolonged half-life of the drug. Okay, so what are the implications of these pharmacologic properties on drug use? No? So we know that it's well absorbed orally with or without food. So hindi siya mabusisi, no? We don't have to worry about that. And that it's highly protein bound, as I said, more than 99% protein bound. Therefore, if we have patients who are hypoalbuminemic, then there may be an increase in active drug. No? So this is something we should worry about as clinicians. And the enterohepatic circulation explains the long half-life, which is good in a way, no, for some of our patients who sometimes miss their doses, but it has very important implications in toxicity. So if we have a patient who has drug toxicity, then we have to control this part of the process, no? And the participation of several enzymes in its metabolism and elimination means that we have to think very well of drug interaction. And remember that some people, we are heterogeneous in terms of genetics, so this may also explain the differences in how the drug works. Okay, so let me now go to the next part of this lecture, which is on the landmark clinical trials on leflunomide for rheumatoid arthritis. I know it's a busy slide, so let me just walk you through this. So the first study I'm showing you here was published in 1995. And this was a multi-center double-blind RCT, which is over 24 weeks. And this was conducted in several centers in Yugoslavia. They had around 400 patients. And if you look at the characteristics of the patients, more than 90% of them are on an NSAID, more than 30% on a corticosteroid, and an average number of one failed DMARD. So the interventions compared where, well, you have to understand this is a dose ranging study. So they compared several doses of leflunomide, which are 5 milligrams, 10 milligrams, and 25 milligrams per day. And these were compared with placebo. So the outcomes they had were ACR 20. And if you look at the 10 milligrams and the 25 milligrams per day doses, the ACR 20 were quite close, no? 52 and 60% are not too far from what we see with biologics. Okay, the change in, so this is function change in HAP. We also see the greatest improvement in function with the 10 milligrams and the 25 milligrams per day doses. If we look at safety, there were some issues with the occurrence of rash or infections, but these occurred at the same rates for all the groups, all the treatment groups. But most notably, the GI adverse effects, in particular, diarrhea, was a little bit higher in the leflunomide group. And there was the issue of reversible alopecia in the 25 milligram leflunomide group. If we look at withdrawals due to adverse effects, these are the numbers of patients who withdrew. So that's 3 for the 5 milligrams per day group, 7 for 10 milligrams, 11 for the 25 milligrams, and 2 for the placebo group. So not very many withdrawals. Okay. So this was, I guess, this is the reason why eventually the 20 milligram per day was chosen. If you look here, there was a loading dose of 100 milligrams that was given, no, for the 10 milligrams and the 25 milligrams per day group. So this was the first study. The next one was published in 1999. I think we are all very familiar with Professor Smolin, a very big name in rheumatology. So this was a study, also a 24-week study among RA patients, again, multicenter double-blind RCT in 12 countries. So I don't know if this was where the Philippines participated, no? And the patients included here, 80% of them were on an NSAID, 30% on corticosteroids, and 50 to 68% were DMARD naive. So in this study, leflunomide with a 3-day loading dose, 100 milligrams per day, and eventually given as 20 milligrams per day, was compared with sulfasalazine, 2 grams per day, and placebo. And again, if you look at the efficacy endpoints, which were ACR 20, leflunomide and sulfasalazine were comparable, much better than the placebo. And you see also that the function was improved, most notably in the leflunomide group. In terms of withdrawal due to adverse effects, we see 14% in the leflunomide group and 19% in the sulfasalazine group, and much less in the placebo group. Okay. So this slide will show us clinical trials which are much longer in duration. No? So this is a study. The first one was conducted in the US and Canada. And you will see later that the second one was done in Europe. Parang mirror siya, no? So it's a reproduction of the study. So these were for 52 weeks. And again, a lot of the patients were on NSAIDs and corticosteroids. So you can imagine that these are patients already with long-standing RA and refractory to treatment. So in the study of STRAND, leflunomide was given as 20 milligrams, and it was compared with methotrexate, given as 7.5 to 15 milligrams per week. And again, there's a placebo group. So if we look at ACR20, we see a figure of 52% for leflunomide, and very close to it is what we get for methotrexate. And functional improvement is significantly better in the leflunomide group. But what is good with this trial is that they also had they looked at radiographic progression, which is important to us, no? Something which we can measure in a study which is longer like this one, because it's 52 weeks in duration. And we see that the sharp score, no, progress, so an increase in sharp score or a higher sharp score signifies a deterioration in or a radiographic progression, no? So we see that the best performance seems to be in leflunomide, not very close behind is that in methotrexate. Now, in terms of safety, again, I'm reporting here withdrawals due to AEs, and we see slightly higher, definitely higher withdrawals in the leflunomide group. There were more withdrawals secondary to GI events like diarrhea, and there was some concern about hypertension. So we just need to be aware of these things that we have to prepare for. Okay, so the other study, again, a study by 52 weeks. So what's special about this is that this involved a really large number of patients. Now, almost 1,000 patients were enrolled in the study. And after the randomized control trial period of 52 weeks, there was an open label extension, another 52 weeks. Again, the patients were established rheumatoid arthritis, a lot of them on NSAIDs and corticosteroids. And the comparisons were leflunomide and methotrexate. Again, they looked at ACR20, disability score, the HAQ, and here the radiographic progression or radiographic status was assessed using the Larsen score. So during the first year, there was a small equivalent increase in the Larsen score in both groups. So an increase in the Larsen score is a deterioration, no? Radiographic deterioration. On the second year, the Larsen score in the leflunomide group was maintained, was stable, and there was a slight decrease in the methotrexate group. So again, looking at safety, reported as withdrawal due to AEs, we see 19% for the leflunomide group and 15% for the methotrexate group. Okay, so I'd like to summarize the adverse events from these clinical trials, no, because of course, these are things that we have to be very much aware of so that we can prepare for them, we can educate our patients about them. And the most common, really, as I've mentioned the past two slides, were diarrhea. I'm not quite aware if these are transient or if these are more prolonged. But I think these are quite transient because we do not see this much withdrawals. No, respiratory infections were also quite frequent, and there are the other AEs that were seen, 5 to 10%, that we have to educate our patients about would be the risk of alopecia, hypertension, no, a rash, abdominal pain, and abnormal liver function tests. And from post-marketing reports, again, we have to be aware of this, that there are reports of various adverse effects in different parts of the body. Okay, so so you can go through the slides. Some of them are innocuous. Many of them are something that are really quite severe. Of course, if it's reported in a post-marketing report, then it's something that we have to pay close attention to. No, again, of course, these adverse effects. As doctors, we know that adverse effects are always possible. So it's best that we know them so that we can choose our patients well and educate them and prepare them for this. No. Okay. So I've shown you studies which were 24 weeks in duration, and the longer studies were 52 weeks in duration. This is a longer study, which had a 5-year follow-up by Dr. Calden. So this is a 5-year follow-up study among patients with RA. If you will notice, this is a large population, 1,838 patients. This came from the trials of Emery and, I believe, Strand. So from this large group of patients, 214 patients continued on to be followed up for 5 years, and 50 of them withdrew, no, because of various reasons. Okay, so what did they see? Usually in 5-year studies, our concern would really be to see if efficacy is sustained, no? And also if safety is sustained. So the bars for the different ACR percentages are for the different years. And just eyeballing, we see that the response rate is consistent, essentially. That's the message here. And with regards function, it also seems to be persistent. No? So a decrease, a dip, is an improvement in function as measured by the HAQ. And we see that it's from year 1 to year 4 and year 5, then very sustained improvement in function. So this is good. We also see that, this is really reassuring for me because this is over a 5-year study, and we see only 4 patients had to discontinue due to liver function abnormalities. There were 6.6% with elevation, or 12 patients with elevation in ALT, 18 patients with elevation in AST, and a few others. But for me, what's very reassuring is that those who had ALT elevation more than 3 times, there was only 1. And serum AST elevation more than 3 times, there were only 4. And as I said, only 4 had to discontinue due to liver function abnormalities. Okay, so I decided to show this slide. This was interesting to me when I did my search of the literature. This interested me because here, although this is a small study of 40 patients, 20 of them were given rituximab, 500 milligrams on day 1 and day 15, and another 20 were given leflunomide 20 milligrams daily, with a dose range from 10 to 20 milligrams per day. So these were patients who still had active rheumatoid arthritis despite use of methotrexate 10 to 20 milligrams per week for 6 months. And if we look at their outcomes at week 24, they had very similar ACR responses as well as rates of serious adverse events. And going down from ACR 20 to 70, you see how similar these are for rituximab and for leflunomide. Okay, so I'd like to now go to the thought of combination therapy, no? So I have mentioned earlier that leflunomide works by inhibiting de novo pyrimidine biosynthesis and thereby regulates lymphocyte proliferation. On the other hand, the right side of the screen, we see that low-dose methotrexate does its work by inhibiting cytokine production and inhibiting purine biosynthesis, as well as promoting the release of adenosine, which is a potent anti-inflammatory. So one might think, inhibition of pyrimidines, inhibition of purines, would that be a good combination? So let's see what studies show. No? So I found this network meta-analysis. So this is a systematic review and network meta-analysis published in the BMJ in 2016. And the population in this study, they chose studies which enrolled methotrexate naive or methotrexate inadequate responders, and they compared methotrexate monotherapy versus methotrexate combinations with various drugs, whether they be conventional synthetic DMARDs or targeted synthetic DMARDs or biologics treatments. And they looked at ACR 50 as major clinical improvement, radiographic progression, and withdrawals. And they looked at Medline and MBase and Central up to January 2016. They also looked at Cochrane reviews and abstracts from rheumatology meetings and trial registers, 2 trial registers. Okay, so if you look at these very beautiful looking diagrams, there were 93 studies on methotrexate naive patients. And these are the different comparisons, no? And there were 67 studies on methotrexate non-responsive patients. Okay, and I tried to summarize what all of these, what they found, no? So among methotrexate naive patients, the ACR 50 for the combination treatments, it ranged from 56 to 67%, which was better than what was seen for monotherapy, for methotrexate monotherapy, which is only 41%. In terms of radiographic progression, methotrexate combined with a biologic DMARD was better than methotrexate monotherapy, but did not meet the minimally, ano nga ba yung MCID? Minimal clinically important difference for the SHARP score. Okay. And the withdrawals, Well, here they said less with the triple therapy. So triple therapy is methotrexate, sulfasalazine, and hydroxychloroquine. So withdrawals were less compared with the methotrexate and infliximab group. What about the methotrexate non-responder group? So in this population, the ACR 50 for the triple therapy was 61%. And for other combinations, it ranged from 27 to 70%. And there was no difference in the radiographic progression for all the comparisons. And when it comes to withdrawals, what they said was this was less with the methotrexate and abatacept group. But what was the main lesson from this network meta-analysis? It said that among patients with established RA, methotrexate-based DMARD combinations were better than methotrexate monotherapy for methotrexate naive and methotrexate non-responsive patients. Okay, so I wanted to share that. Okay, so the next study that I will show you is slightly different because from the study or from the dose ranging study until the 5-year study, all of those included patients with established rheumatoid arthritis, some of them very, very long duration of disease. But the CARE RA trial is different because the population here are those with early rheumatoid arthritis. So early rheumatoid arthritis means disease duration of 1 year and below. Okay. And it's also interesting, well, aside from the fact that it's a 2-year investigator-initiated study, it's a randomized, pragmatic, open-label superiority trial. So I was interested in it being a pragmatic, randomized trial, which mirrors real-world experience. Okay, so the population they had were DMARD naive early rheumatoid arthritis patients, and they were also glucocorticoid naive. No, yun yung inclusion nila. And they divided the patients into low or high risk groups, depending on whether they had erosions, disease activity, and whether they were seropositive, rheumatoid factor or anti-CCP. And there were several remission induction regimens given in a treat to target approach. And you see the 4 regimens here in the table, no? So, Cobra Classic, Cobra Avant-Garde, Cobra Slim, and methotrexate tight step up. Okay, so all of these treatment groups had a core treatment of methotrexate, which was initiated at 15 milligrams per week. The Cobra Classic had, in addition, sulfasalazine given as 2 grams per day, and prednisone given at a high dose, 60 milligrams, and that was eventually stepped down. The Cobra Avant-Garde had an additional leflunomide, which was given at 10 milligrams per week, and prednisone 30 milligrams, which has again eventually stepped down. And the Cobra Slim had methotrexate and prednisone 30 milligrams, and the methotrexate tight step up only had methotrexate 15 milligrams per week. All the groups which were given prednisone had weekly tapering to 7.5 or 5 milligrams over the next 6 weeks. So meron silang standard regimen na from 60, it goes down to 50, etc., etc. And from 30, it goes down to 25, and etc. So meron silang program on how to taper weekly until either a dose of 7.5 or 5 milligrams over 6 weeks is reached. And then they maintain that until week 28. And then after week 28, then they again gradually taper until the steroid is stopped on week 34. So if patients were or had a DAS still 3.2 on week 8 onwards, then this is where it's like our real world experience, no? They allowed up titration of the DMARD. And they allowed this up titration twice at 8-week interval. Okay, so their goal at week 40 was to be able to achieve DMARD monotherapy. For the avant-garde group, that's the group where there is leflunomide, then at week 40, they re-randomize to either leflunomide or methotrexate. Okay, so diba, it's very interesting. It's something that seems to mimic real-world experience. So how do they up-titrate? Meron din silang programa on what to do in up-titrating. No? So the first step will be to increase methotrexate to 20 milligrams per week, whichever group it is. No? And then the second step, if this is the Cobra Classic, if you have to do an up-titration a second time, then the sulfasalazine is increased from 2 grams to 3 grams. If this is the Cobra Avant-Garde, then the leflunomide is increased from 10 to 20. And well, for Cobra Slim, which is a monotherapy with methotrexate, then they add leflunomide, 10 milligrams. So at the end of this, what did they find out? No, what were the results? So they had DAS28 CRP remission at week 52. So at 1 year, ano ba yung remission rates? So what's so interesting is very similar, no? Whatever treatments they were given, they had very similar remission rates, whether they were high risk or they were low risk. And the adverse events, if you compare to the Cobra Slim, were the same for the methotrexate tight step-up group. And there were more adverse effects for the other combination groups. So this is, well, for me, what was very interesting is that at week 52, 76% of their patients were able to maintain DMARD monotherapy, and only very few still needed glucocorticoids, and also only 7.5% needed biologicals. So, well, the author's conclusion was that they favored Cobra Slim, no? Because it seems like you can use it for anyone, whether high risk or low risk. But for me, it gives us a wide range of possibilities for the different kinds of patients that we have. Okay. So I just wanted to share that. Okay. So this is the last part of my talk, looking at how we manage rheumatoid arthritis and ano ba yung place ng leflunomide in the guidelines that we have, no? So I chose to show the EULAR guideline because for me it's very simple, very nice to use, and I underlined the keywords, no, that as rheumatologists we have to really take them to heart, no, that we aim at the best care, we apply shared decision making between the patient and the rheumatologist. We base our decisions on disease activity, not only on disease activity, but also on safety, and other patient factors like comorbidities. And, we look at the future. We want to prevent progression of structural damage, and that we are the specialists who should care for patients with RA primarily. And this is very interesting, no? That's why we're happy that we have access to multiple drugs now, is that we'd like our patients to be able to access multiple drugs with different modes of action. And of course, we recognize how very important it is to properly manage patients with rheumatoid arthritis because of its high individual, medical, and societal costs. Okay, so if you look at the guidelines, I tried to summarize them at the left-hand side, no? Parang pagka ganito, pwedeng mas madali yatang matandaan, no? So what the recommendations is that, once you diagnose RA, then you start a DMARD as soon as possible. And everyone should target remission or low disease activity. And it's very important that we monitor every 1 to 3 months. And the first line is methotrexate. But if the patient is unable to tolerate methotrexate, then we consider other drugs like leflunomide or sulfasalazine. So we now have both of these in the Philippines. And glucocorticoids, we want to give them short-term only. And unfortunately, if there's DMARD failure, conventional synthetic DMARD failure, then you can shift to another DMARD, no? Whether it be a conventional synthetic or a biologic or a targeted synthetic DMARD. So we have options depending on the presence or the absence of poor prognostic factors. Among patients who are given biologic or targeted synthetic DMARDs, then we need to combine this with a conventional synthetic DMARD. And for patients who still fail biologic or targeted synthetic DMARDs, then you just have to shift to another one. And for patients who have sustained remission of glucocorticoids, then we can reduce our DMARDs. So, parang madaling tandaan, ano, pag gaganyan. Okay. So, again, looking for leflunomide, its place in our management of rheumatoid arthritis. Then from the guidelines, we recognize that for patients who are unable to tolerate methotrexate or are non-responsive to methotrexate. So I would think we have data showing that's at least 20% up to 40% of our patients, no, can be candidates for treatment with this drug. Okay. And you remember this slide, which I showed you earlier, no, about its pharmacologic properties. So we know it's well absorbed orally with or without food. It's highly protein bound. It has a long half-life, and there are enzymes involved in its metabolism and elimination that we have to pay particular attention to, especially when we consider drug interaction. So how do we use leflunomide in rheumatoid arthritis? The clinical trials use a loading of 100 milligrams per ORM for 3 days. And then we can give it 10 to 20 milligrams per ORM per day. However, I think the preparation that we have is 20 milligrams per day, and it's a film-coated tablet, so it cannot be divided. Before giving the drug, we do our standard tests. No, we have to know the blood pressure, it should be controlled, and we do all of these tests as we do for our patients with rheumatoid arthritis who are being given a DMARD, no? So, alam na natin lahat ito. And we do the same for patients who are to be started on leflunomide. Okay. I think very important that we remember the contraindications. So definitely pregnancy, hypersensitivity, severe hepatic impairment. I'm sorry for the typo, and current treatment with teriflunomide. So this got me thinking, no? Bakit current treatment with teriflunomide? Akala ko ano siya, metabolite. So ito palang teriflunomide ay it was also there is also a tablet, teriflunomide, and it's approved as a drug for relapsing multiple sclerosis. So another thing that I learned from this lecture while researching for this, very interesting. Okay. So I think itong hepatic impairment, we should know this by heart, no? So definitely, we cannot use it for patients with pre-existing liver disease and for those with baseline ALT more than 2 times the upper limit of normal. And it would be, we should think twice before we co-administer it with drugs that are known to cause liver injury. And when we use as part of our monitoring, then after the baseline ALT, we monitor this every 4 weeks for 6 months. And then after that, if it's normal, then we can reduce the monitoring to every 6 to 8 weeks. If the ALT rises more than 3 times the upper limit of normal, then we must discontinue and determine the probable cause. If we decide that it's not leflunomide causing the elevation in transaminases, then we may resume leflunomide. However, if during our evaluation, we determine that it is likely leflunomide induced, then it's important that we do a washout procedure. And this is done using cholestyramine 8 grams per RM 3 times a day for 11 days, best as 11 consecutive days for rapid elimination. Our goal is to achieve non-detectable plasma levels less than 0.02 milligrams per liter twice 14 days apart. So very specific, no, yung goal. And that the LFT be monitored weekly until the ALT value reaches the normal range. Without doing the washout, it will take 2 years to reach undetectable plasma level due to individual variation in drug clearance. Okay, so just more cautions, no, and important to know in monitoring. So, as with other drugs, live vaccines are not recommended. There is a potential increased risk for malignancy. So this is important for us to know, no? For us to choose our patients well. No? Of course, I already mentioned pregnancy, that is contraindicated, and there may be hypertension, so we must monitor the blood pressure. Patients who develop hypersensitivity reaction or peripheral neuropathy, all of these other things, we have to do the washout procedure. But the good thing is for patients who develop peripheral neuropathy, most of them recover after discontinuing the drug and doing the washout. So I also listed here risk factors for this, no, for these conditions. Like for peripheral neuropathy, those who are older, those who are taking other neurotoxic drugs, those who are diabetics. Okay. So also, I think important to note yung immunosuppression, no, that patients who are have severe immunodeficiency, bone marrow problems, and those with severe uncontrolled infections, like for example tuberculosis. So we have to think twice, no, before giving the drug to these patients. We also Patients who are at high risk of pancytopenia, agranulocytosis, and thrombocytopenia are those who are co-treated or recently discontinued methotrexate or other immunosuppressants, or those with a history of a significant hematologic abnormality. So we just really need to monitor the CBC, and the monitoring process is very similar to the timing of monitoring for ALT. And I thought also very important to mention that there may be severe and disabling arthralgia in patients taking DPP-4 inhibitors, and examples are given here. So this is really just so that we are aware of all of these situations. Okay. So I think this is my last slide. It's very busy, but I opted to still continue with it and show it anyway, just to emphasize that if we are giving biologics, live vaccines, and immunomodulators, then we really need to think twice or thrice, no, because there may be serious interactions. And for those at the right side, no, you monitor closely. So yung mga inactivated vaccines, no, so even flu, yung mga recombinant, trivalent, quadrivalent, we have to monitor closely. And some of the drugs that we commonly use in rheumatology, or internal medicine, like carvedilol, losartan, denosumab, warfarin, tamoxifen, methotrexate, phenytoin, then we have to monitor these patients closely. So let me summarize by saying that leflunomide is a good therapeutic oral drug in the treatment of rheumatoid arthritis. So we have basis that it's able to control rheumatoid arthritis. It can be used as first-line or second-line therapy. It can be used in combination with methotrexate, which is the anchor drug in the treatment of rheumatoid arthritis, with close monitoring. So the best candidates for leflunomide therapy are early methotrexate intolerant or those who are non-responders. And I think we should be armed with thorough knowledge of its pharmacokinetic and pharmacodynamic properties, because that is essential for confident and safe prescribing to achieve good outcomes for our patients with rheumatoid arthritis. So with that, I'd like to thank you for listening to this lecture, and I hope that you will be confident in using this drug as part of our clinical armamentarium in rheumatology. Thank you very much.
Thank you very much, Dr. Evelyn Salido, for that comprehensive lecture. That leflunomide is a good therapeutic drug in the treatment of rheumatoid arthritis, and it can be used as first-line and second-line therapy. And with that, may I call on the highly respected Dr. Esther Penserga for our open forum.
Good afternoon, everyone. And thank you, AZMed, for bringing in this product. And thank you very much, Dr. Salido, Evelyn, for that very clear piece, describing leflunomide to this audience. This audience is in fact unique. 150 already, and scanning through the names, I know that I think 80% of them were still in either high school or elementary when this drug was published and approved for treatment of RA. And so I I was having fun actually looking at their names. So thank you very much, Evelyn. That was really a very clear piece, and it served as a reminder also, since I believe I was also involved with the study of Dr. Amante, I think, and I remember clearly that the packets that were given to the patients, to the study patients, had 3 100 milligram tablets, and then before the 20 milligram ones were given. Okay, so let's now go to the questions. The questions here have three. I think they can be grouped into three, no? And there were, I think, 2 to 3 questions asking on the loading dose. What's the advantage? Do we still do it? If you'd like to answer that, Lynn.
Well, the clinical trials they did the loading dose. And one of the articles that I was reading also mentioned that if you do away with the loading dose, there may be a slower onset of effect. But I think the toxicity will also be less, no, if you do away with the loading dose. So what we see, the official recommendation is to load for 3 days. But I think you can, in my experience, no, with using the drug, it works as well if we do not do the loading dose. And I think yun nga, some of the toxicity can be avoided if you do away with it. So it's something there if it's there if you're in a hurry. But from the pharmacologic properties, it's also rapidly absorbed. It reaches its peak plasma level in 6 to 12 hours. So I think there's the option to load, there's the option also not to load. I remember you talking about that, no, sharing your experiences back then, that about the loading. Kayo, ma'am, what do you think? Binalik ko sa iyo yung tanong.
Binalik sa akin, no? Actually, I don't load anymore. And do you think the initial observations of corollary question lang naman, kasi we have several others, no? Other questions. Do you think the loading dose, the at least 300 milligrams din yun, no? For 3 days, would it have been the reason for the higher adverse events observed during those early studies?
Yeah, probably. If you look at the CARE RA, in that study they did not load. And in fact they gave 10 milligrams in that study.
Okay, so actually I also do not load, kaya it's all right. It's very no. The effect is also fast, no? Para siyang methotrexate. Now, the other group of questions here are on the adverse events. So apparently, our audience may have been really impressed, no? At it was always on the higher side compared to methotrexate, compared to the other comparators. So the one important question here is, how common is hypertension as a side effect of leflunomide?
Hypertension is andun siya sa group ng 5 to 10%. Let me just go back to that slide so that I can be sure. I think nandun siya sa 5 to 10%. Hindi nga siya nakasulat eh. Yes, there. Yeah, I see it. So it's 10%. The frequency is 10%. Alopecia, hypertension, and rash, 10%.
Okay. So, ito namang, all the questions here are from anonymous attendee. So it would have been good if I had the names, no? So thank you for the very informative lecture. This is another question on leflunomide and infections. Do we hold leflunomide during active infection during vaccinations?
Yes, I think it's a good idea to hold it, no, during episodes of active infections. Anyway, mahaba nga yung half-life niya. And in fact, for very severe infections, one might, if you think it's a large contributor, then yung iba nga yung some references suggest a washout, no? So it's a good idea to hold it during infections. Ano nga po yung isang question? Vaccination.
Yes.
So I showed you mahaba yung listahan nila actually ng sa vaccination no?
Mhm.
So yung that's in my last slide, no? So if you look at the first column, those are a lot of most of these vaccines are yung mga live, no? Yung karamihan dito, but masyado na lang kasing mahaba. There were also a few of the vaccines here which were also inactivated. So I showed this because just to inculcate that idea that we really have to be very careful with our vaccines, no? So better kung ibigay na muna yung mga vaccines before we start leflunomide. Pero for those that have to be given annually, like the flu vaccine, then ano lang naman, monitor closely.
Okay. So then the other group of questions here, no, kasi dumadami, is on either to switch from methotrexate non-responders, shift to leflunomide, or is it better to add on? So what I think merong studies nito actually, no? So maybe they want it emphasized.
Yes. Well, actually to shift or to add on are both possible actions, no? Because it really depends on the clinical situation, because if methotrexate intolerant, then maybe it will be shift. But if methotrexate non-responder, then it's possible to combine. Kailangan nga lang talagang i-monitor closely, no? Also possible to shift.
Okay, which would bring us to this next question. No? The question is on bakit hepatomegaly? Hepatotoxicity pala. With methotrexate, and then when it has resolved, and leflunomide is started, would there be an anticipated similar effect?
Yes, kaya nga in-emphasize ko yon, no, na we have, if ever we decide to combine them, then we only do that if the liver function is good. No? Kasi nga, contraindication, it's not recommended that we give leflunomide among patients with ALT more than 2 times the upper limit of normal. So if in the first place, the problem is a transaminitis, the problem with methotrexate is a transaminitis, then and you decide to shift that patient to leflunomide, then you also have to monitor very closely.
I think I remember one of the slides you had was that 2 times elevated ALT elevation will still be acceptable to start leflunomide, was it?
Ito ma'am, not recommended
Not recommended.
for pre-existing liver disease. And it's not recommended if the baseline ALT is more than 2 times the upper limit of normal.
Ayun, may palugit pa. Up to 2
Yeah.
times, we can still start leflunomide with very close monitoring. And then still corollary regarding the liver, Therese is asking, in hypoalbuminemic states, are there dose adjustments needed?
Difficult question. I don't know. I didn't see anything about adjusting the dose. But I guess that's a situation wherein we should monitor the patient closely kasi you will have more active drug if the patient is hypoalbuminemic. And so maybe in terms of monitoring the ALT and the CBC, instead of monthly, we can do it more closely, like every 2 weeks.
Mhm. So thank you, Lynn. I hope that answers your question, Therese. Again, in connection with toxicity, somebody brought up cholestyramine.
That's tyramine, yeah.
Yes, is it useful also?
Well, I asked the help of AZMed if they can, because that's the protocol in all the references that I looked at in terms of toxicity. That's the watch out recommended. And I remember even in the clinical trials that we participated in, kung kasama yung leflunomide, I remember cholestyramine as being mentioned, that it be given this way. Hindi ko lang alam kung available siya sa Pilipinas. What we found is cholestyramine present in combination with diclofenac. So we still need to search for the plain cholestyramine. Pwede siguro tayong magtanong sa mga pharmacologists.
Yes, another question. Talagang somehow the lecture brought out a lot of mga questions dito on toxicity. How about the combination with hydroxychloroquine? Why is it unsafe?
Yes, it's here. Naku, hindi ko yun naaral. Whoever asked that question, I need to go back to you because if you look here, immunomodulators, possible serious drug interaction. I don't know the answer. Sorry. I will look for that.
Okay, so if you can send us your name, not anonymous, then you may have the answer, or you may also communicate with Dr. Salido. The other questions really were on itong dosing, side effects, and toxicity, and then combination therapy. So it's very telling that our audience really got the gist of having a new, it's an old but a new option for, which is a synthetic DMARD for the treatment of RA, just given these different questions. Okay, so I think we are we done? No other questions? How about this in the chat? Are these questions? Di naman, no? So these are panelists. Okay, so I think we can go to a short summary in terms of this lecture today has provided us a glimpse of the past. In fact, it was going, Dr. Salido went through several important decades of her life, and possibly that was a very good way of connecting us, connecting us with the different milestones of different drugs for RA. It is true that while we lost the use of leflunomide for almost 20 years, it is back, and I hope that AZ Med will be able to continuously supply us with the drug. And meron pa ako ditong, yes. I think the lecture also was very important in terms of bringing our very young audience to the seminal years when the treatment of RA finally got some hope, glimmers of hope with the new drugs that were coming in. And imagine yourself, imagine during, I don't know whose time, but I can see, Dr. Turalba. Hi, sir, Dr. Turalba. During those times when, good to see Dr. Turalba around. I can see that during my, if I may continue, during those times when we only had not even hydroxychloroquine, but chloroquine mismo, no? And steroids. And then gold was something that at 29 pesos per tablet, the patients cannot afford during those times. So, well, at least from the practice that I had then. And so thank you very much, Evelyn, for bringing us through the past and introducing to us and to our young audience this new option that they can take, and explaining all the doubts, and maybe also enlightening the doubts in terms of combination with the base DMARD that we use, which is methotrexate. And if there are no more questions, I think one more pass. Ay merong humabol. Which is your preference, 10 milligrams or 20 milligrams as a starting dose? Evelyn.
Most of the studies used a 20 milligrams. But if you look at the dose ranging study, the 10 milligrams in the 24-week study is very close. And if you remember, the early RA study used a 10 milligram with the option to increase to 20 milligram.
Okay. And so
I cannot give a very
choppiness.
But we look at the patient profile. Naghang.
Okay, so
Hello.
okay. O naghang
Okay.
audio lang ba ang meron?
Can you hear me?
Yes, yes.
I'd also like to answer the question about hydroxychloroquine and leflunomide combination. Nagkakaroon ng B-cell suppression, B-cell activity suppression. Okay. So not a good combination. So
Okay.
if I think the message here is that this gives us more leeway. It's an in-between, it's an option for patients who cannot afford biologics but are not responsive to methotrexate. So it's an option that is there for us.
Okay, so I think there are no pahabol questions. We'd like to thank Dr. Salido for this very enlightening lecture and our walk through memory lane for us who have been there and done that. And I think there's another question here that will just be for the next number of our program, which is how much? Okay, so thank you very much. Thank you, audience, the anonymous. Ang nakilala ko lang dito, si Mark Jason, si Therese, and si John, at si Nico ang may pangalan. So all the anonymous, thank you also for your questions. Okay. That's all for my part.
Maraming salamat po, Dr. Penserga and Dr. Salido, for that enlightening discussion and sharing your valuable insights. Para po sa mga iba pa pong katanungan, maaari po namin sagutin, lalo na po sa pagtatanong ng price about leflunomide. Maraming salamat po sa pagkakataong ito para i-launch po namin ang aming produkto, Bageda. And I'll take this opportunity also to promote our other products, methotrexate, Metorex, febuxostat, Pepsan, mycophenolate, Myotec, hyaluronic acid, Hyaruan. And in behalf of AC Pharma, maraming salamat po sa kabuuan ng PRA. Maraming salamat po, Dr. Emmanuel Perez, Dr. Salido, Dr. Penserga, and Dr. Manapat Reyes. Thank you very much po for this opportunity for having us launch Leflunomide Bageda, our product.
Magkano nga, Sheila?
Doktora, ito pa po. Doktora, yung katanungan po kung magkaano po ang Bageda po ay 110 pesos per tablet.
Okay. So where is it marketed? Where can we source it?
Sa ngayon po, maaari pong lumapit sa aming medical representative o sa amin po diretso sa aming opisina. Babanggitin na lang din po namin ang aming cellphone number. Pwede po kayong kumontak sa 0917-511-9521. Hindi pa po siya direct available sa Mercury at sa iba pong drugstore. So direct pa po makukuha sa AC Pharma.
Okay, thank you very much, Sheila.
Maraming salamat po, Doktora.